Thank you for the kind introductions to the chair people and to Philip and Juliana for the invitation to visit Hong Kong. It's always lovely to be here. And Peter's a really hard act to follow, and I don't have any jokes, and I can't blame Adrian for being a bad presenter. So I'm going to give it a go, and I think I've been given the hard task of getting back to the evidence, and that's the root of all of what we do, really, is try and deliver evidence-based practice. So I'm going to do speed dating on the mega trials over the last decade and hopefully give you some take-home messages. These are my disclosures. So I'm going to cover what we've learnt from the mega trials, trials of more versus less, trials of new oral agents, trials of new injectable agents, maybe that's aspirational from the cost perspective, and where do we move from here. And so just quickly, why do we need evidence for therapeutic approaches? Well, we've already heard today how complex diabetes is, particularly type 2 diabetes in terms of its pathophysiology and the fact that it's a progressive disease. And as we've heard today, there's no specific treatment algorithm that will be appropriate for all patients. We've got lots of new therapies. We're not sure how to and when to apply them, and there's a rapidly emerging evidence base. And we really want to talk about personalised medicine, but we're not quite sure how to do that. Do we look at phenotype? Do we look at genotypic expression? And what about trial and error and healthcare provider experience? So I'm going to take you back to the trials of more versus less, and it all started with the DCC edict, which is a study in type 1 diabetes and done many, many years ago, in fact more than 3 decades ago, and it was the first more versus less glucose control trial that looked at intensive insulin treatment, and it showed a raft of improvements in diabetic complications, both microvascular and then towards, as there was more long-term follow-up, even cardiovascular disease prevention. And that paradigm was mimicked in the UK PDS study, again a historical study now done many years ago, but again a more versus less glycemic control trial where it looked at in an in-trial period effects of different approaches to glycemic control, but also did a post-trial follow-up study examining whether those initial accrued effects would increase over time. And as you can see there, we can see the effects during the legacy stage of the trial and benefits emerging and giving us that lesson learnt that if we intervene early at the time of diagnosis, as they did in the UK PDS trial, then effects would emerge over time and we'd actually change the trajectory of those complications in those individuals who had better control. We then move on to the more contemporary trials in the sort of early 2000s, and these were the Accord, VADT and advanced trials, and I can't not talk about the advanced trial. I've got Nicole here, I've got Juliana, I've got lots of colleagues from China that all participated, and I would like to say that the region that was heavily involved in advance and the way they delivered the more intensive glucose control was one of the reasons why the benefits were observed in that trial as compared to some of the harms that were observed in Accord particularly. And you can see here for Accord and VADT, I'm going to quickly summarise it, open label glucose control, more versus less, targeting A1C of 6 or 6.5. Standard therapy was as per usual practice, mean follow-up of 3.7 and 5.6 years during the treatment period. Between group differences in A1C of 1.1 and 1.5%, and in both trials they got very close to that 6 and 6.5%. However, the Accord was terminated early due to increased total and cardiovascular mortality, and the VADT thankfully was not terminated early, but there were no major cardiovascular benefits observed, and we are, oh my gosh, you know, more glucose control is not important. In fact, we need to focus on other things. Or is it the approach to the more intensive glucose control which is having the untoward effects? In contrast, in the advanced trial, and this is looking at the summary of the results, in the intensive glucose control arm, again targeting A1C of 6.5%, using a very pragmatic approach. It was sulfonylurea based, and I know that's a dirty word now, but I'm going to say they're still a very highly effective treatment for glucose control. And although treatment failure does occur more rapidly than some other classes of drug, still can be used even in an insulin-sparing way for many, many years, and we just have to know how to use them and how to mitigate the risk of hypoglycemia. So what did we show? Again, it was lots of therapies, but sulfonylurea based with gliclazide MR, 10% reduction combined macro-microvascular outcome, 14% reduction in microvascular events, 21% reduction in new or worsening nephropathy, however, no mortality benefit. And that was an average of about almost 5 years of treatment. So what happens when we group things together? And we've heard all about multi-risk factor management and the Steno trial, very small study, and we've great data presented today. I've been really impressed. And what we saw when we combined it in the advanced trial, because it was a factorial trial where there was a blood pressure lowering arm that was an ACE inhibitor therapy, and when we combined the blood pressure arm with the intensive glucose control arm, we can see that the benefits are additive, and this is looking at effect on all-cause mortality, 18% reduction in risk, and you can see there the numbers needed to treat of 56, which is low. So let's deep dive a little bit more, and we always do this with big trials. We spend a lot of money in delivering them, and then we want to really try and understand more and more about what's happened during the trial and what happens around specific outcomes. And again, these aren't the primary hypotheses being tested, but it's still important to make use of that data that's been accumulated. We had the opportunity in the advanced trial to really examine that end-stage kidney disease outcome, and since then you'll know that the outcome has evolved in a quite progressive way. And now we think more completely about the types of compensates that are being accepted in new trials for chronic kidney disease. So this is looking at separating the different sort of renal outcomes, if you like, end-stage kidney disease, which was obviously end-stage requirement for dialysis or renal replacement therapy, renal death, or doubling of serum creatinine, as you can see there. And we can look at, in what we discovered in the advanced trial, the definition of doubling of serum creatinine was actually not purpose fit, because it didn't look at whether the creatinine was increased in a sustained way. When we looked at that, in fact, when we just looked at doubling of serum creatinine, that included acute kidney injury, and in fact, the point estimate looked like that intensive glucose control caused harm. However, when we looked at much more sustained doubling of serum creatinine, in fact, it was in the direction for benefit. So you can see there, the way we define the renal outcomes is really important for these trials, another lesson learned. And as you know, the FDA and other bodies are now include a more broader concept of what renal endpoints could include. So we had the opportunity to follow up the cohort also, as they did with UK PDS for the advanced trial, and we followed them for another 5 years. They had an overall total of 10 years of follow-up and experience. And as you might imagine, although during that randomised period there was about a 0.7% difference in A1C, that those differences soon converged, and in fact the levels of A1C were the same. So what we saw was that in the intensive group, A1C went back up to 7.3, 7.2%, not quite to where it was when we started. And you may say, well, why did that happen? There was no harm shown with it in the advanced trial. Well, when you've got these other trials like the Accord study saying, well, intensive glucose control is a bad thing and it kills people, you know, that although that's not your trial and it's the other trials, people start worrying that they should do less. And you can see there in the standard group, in fact, their A1C stayed about the same, and a little bit better than what it started with. So what did we show with the legacy trial? Well, there was no legacy benefit for mortality or major cardiovascular events, but there was for sustained and significant reduction in end-stage kidney disease. And we felt that this effect was due to the benefits arising from that original trial period of intensive glucose control, and those effects persisting into the post-trial period. And I can show you here the way it looks. So you've got there the Kaplan-Meier curve, cumulative incidence of end-stage kidney disease as it was defined in the in-trial period. And you can see there in the tabular form on the side that the number of events obviously is quite low, and that's the complexity and the difficulty of doing these CKD end-stage kidney disease trials where the events are still very rare, and that's a good thing, but it's really hard to show that an intervention is going to work. So we were able to accumulate further events in that post-trial period and show that there was a significant reduction in end-stage kidney disease. Hazard ratio of 0.54%. Gee, that's pretty similar to those SGLT2 inhibitors, isn't it? So one might say, and what I've been really worried about with these new classes of drug is, you know, you can't throw out the baby with the bathwater. You know, people just say it's the type of drug you're using, not the glucose. And yeah, sure, we now have drugs that do work and they're renoprotective, but we shouldn't forget that you might get extra benefit if you've got a good glucose control as well. And we're hearing that a lot with nephrologists and cardiologists particularly, that say it's not about the glucose, it's all just about the drug. And I don't really think they think about the complexity and the multi-risk factor approaches to disease prevention or treatment. Now, what you can't see there, and on my slides, for some reason, the formatting's gone wrong, is the VADT, no benefit during the intratrial period. There was sort of this trend to renal benefit. And they did do, again, similar to us, a post-trial follow-up study. They followed them for 15 years, their cohort. It was a smaller cohort of just less than 2,000 patients. And in fact, they also showed legacy benefit for a renal outcome. And their renal outcome was a little different. It was based on estimated GFR and urine albumin-creatinine ratio, so eGFR of less than 45 mils per minute or UACR greater than 300, but they still showed about a 19% reduction in that outcome. Again, a legacy benefit for renal outcomes. So 2 post-trial follow-up studies, similar, both showing benefit for the serious kidney disease outcomes. All right, so we can group the data together, and we have this opportunity to do this amongst these major trials, the control collaboration it was called. They first reported a major cardiovascular events, and again, this is happening in the environment of, well, intensive glucose control is not good, but here you see, even for cardiovascular events, major cardiovascular events, the effect is there. It's modest, yes, but it's still there, 9% reduction in major cardiovascular events when we treat more intensively than less intensively. What about if we look at renal outcomes and the other microvascular outcomes? Well, we had this opportunity. Now, this was an IPD, so that the trials brought their data together, 27,000 participants, 1,600 kidney events, almost 800 eye events, and over 7,500 nerve events. And what did we see? Well, again, we saw similar to what we saw with some of the other trials, was about a 20% reduction in kidney events of more versus less glucose control, and a 13% reduction in eye events. Unfortunately, we didn't see any reduction in nerve events, and we postulated this was because the way we were measuring nerve events, it's very objective. And so we felt like we didn't have good tools of actually assessing for peripheral neuropathy. And so I think that this is, just a limitation of the way we measure these particular outcomes. So more versus less, good for the eye, good for the kidneys. All right, well, I've talked about harm, and I think we were very interested that although we did not observe any harm in advance, ACCORD showed increased mortality, and we were interested in, was it related to the approaches? And there was a lot of studies reporting on why did ACCORD report, and have to be terminated early. Well, we again had the opportunity to use the advanced data set as an observational tool and to try and examine the relationship between hypoglycemia and adverse outcomes. And we did this, we felt there was a hypothesis for why hypoglycemia might induce cardiovascular events, stress, sympathetic response, inflammation, all those particular reasons. But we wanted to then look at, was it a very specific association relationship or was it non-specific and a marker? And so we did this by looking at a range of outcomes, and we felt there was no biological plausible reason for why hypoglycemia should increase those outcomes. And we actually showed that the risk was increased for those outcomes as well. So the lesson learned here was that this hypoglycemia was, in some cases, could be an exposure or cause of an adverse event, but clearly it was also a marker of vulnerability of other illnesses. And now the focus is really in our routine clinical care is, if someone reports particularly severe hypoglycemia, we need to think about not only what's caused it or why, but what this could be contributing to in terms of frailty, other comorbidities, and prognosis. So, and this extends to that, to now think about, and we've talked a lot about glucose targets today, of thinking back to that relationship of the way glucose relates to adverse clinical outcomes. And it's clear, and I think we need to accept this, that the relationship, unlike what UKPDS told us from their observational analysis of the relationship between glucose and micro and cardiovascular outcomes, the relationship is not completely linear. It's non-linear, and there's a threshold, and you'll see those curves there that we plotted for advanced, but it's been reported by other studies as well, that affect the risk changes at around that level of HbA1c of 7 or 6.5%, And you can go lower to see benefit for microvascular, but you tend not to see greater benefit when you go lower for cardiovascular events. So A1C of 7 seems to be about the right threshold, or that inflection point where risk starts to climb, and for microvascular kidney events, it's about that 6.5%. So clearly providing a rationale for what our targets currently are. All right, we've gone beyond that now, and now we're looking at the approach to more glucose control. And you'll know that in 2022, the GRADE trial reported, and this was a trial that looked at, it was a comparator trial, and we'd never had these trials before at this sort of scale. Unfortunately, it was designed at a stage where we didn't have all those new therapies that we're now using, and now we've got a whole bunch of new therapies, particularly new injectable GLP-1s and the SGLT2s, and these weren't studied in this particular trial, which was comparing one approach of add-on to metformin and looking at metabolic failure as A1C that goes above 7%. And you'll see there the drugs that were used in that particular trial: insulin glargine, liraglutide, glimepiride, and sitagliptin. I always find with the trials that are based in the US, and that's no criticism of the US, but they always use the worst sulfonylurea, and they always use insulin, and so, sometimes I feel that they're not a fair, fight, right? So anyway, so this was looking at add-on and monotherapy, so it's single to dual therapy, and what was sufficient or durable for keeping the A1C less than 7%. And you can see there, they all work, right? They all come down, the A1C does come down. However, what performs less favourably is the sulfonylurea and the sitagliptin. And I'm really surprised the sitagliptin did actually the worst. And actually, from my own clinical experience, I have found that as a class of agent, the DPP-4 inhibitors are not very good glucose-lowering agents. They help where you've got to get them that little bit extra down to where you want them to go. But clearly, if someone's 2% above the target, they're not going to get them there. And so if you're looking at cost, back to Adrian's point, go for where there's bang for buck. And we've got a whole bunch of other drugs that we can use that are much more efficacious. Now, so you can see there the Nike curve, they all fail eventually. Some fail more than others, but clearly we need more than one agent, and we need to know how to combine them. So lesson learned there. All right, so summary of more versus less. We've got all the trials that showed there were some benefits, modest benefits of more versus less, but also some risks we need to think about. UK PDS, go early. And in fact, some of them maybe go early, so even in those with established disease, try and go early to have those legacy effects for kidney benefits. How you lower glucose is important. So you need to avoid hypoglycemia. And clearly, the kidneys and the eyes are very responsive. All right, then we've got the other mega trials. Now, all these new approaches and classes of drugs are being, investigated, and this is great stuff. We want more tools in our toolkit, and we want more, opportunities to get people to target. So I'm going to focus here on obviously SGLT2 and GLP-1s, and this is not death by PowerPoint, but there's a few more slides to see. Just some of the take-home messages. As you all know, different approach to renal benefits, particularly in heart benefits of this new class of drug. And as we heard earlier, now they're telling us we should use them for everyone, for everything. And a whole bunch of trials being done, all large-scale, well-designed, multinational, and for a range of different indications. So main take-home messages we can see here. SGLT2 inhibitors, this was the empagliflozin, major benefits for reducing the three-point MACE and heart failure in the context of secondary prevention. We heard about how that's important, when to intervene. No heterogeneity when we looked at specific subgroups, including by baseline urine ACR. So, irrespective of your risk, you're going to benefit from this class of this drug. For here, Declare-Timi was the first one that showed a primary and secondary prevention. Again, major benefits for heart failure hospitalisation and a composite of heart failure hospitalisation and cardiovascular death. So again, a bit earlier, you can still observe these effects. When we go to late-stage disease, and this is DAPA-HF trial, you can see there, again, that cardiovascular death, hospitalisation for heart failure, major benefits of this particular class of drug. And here we're now, what's emerging here is we're including people without diabetes and showing that these effects translate into populations with heart failure without diabetes, and there's no heterogeneity. and very small numbers needed to treat there. And we're talking here late-stage disease with a reduced ejection fraction of 31% on average. And again, I think another take-home message from these trials is the short period of treatment to observe these effects. You can see there in that cumulative incidence curves, the curves diverge almost immediately and then stay separated. All right, and then finally, we had a kidney-focused trial, where those of us who work in diabetic kidney disease, it takes so long to accumulate evidence. And here we had another EMPA kidney trial, median follow-up of only 2 years. CKD, as you can see there, defined as EGFR of 20 to less than 45 mils, or 45 to less than 90 mils with macroalbuminuria, UACR greater than 200. And you can see there that, obviously SGLT2 inhibitors, major benefit, and that was irrespective of diabetes status. So again, this paradigm that you don't have to have diabetes to see the benefits of this class of drug. All right, so summary of SGLT2 inhibitor trials. Got lots of trials showing that they're superior to standard care in a diabetes population. Now we have them for a heart failure population and a kidney population. Clearly, availability and access and implementation is the key thing here. Now, I'm not going to talk about how we prescribe them. We heard earlier they're not always the easiest drug to use, but with clear, good education, addressing literacy, addressing concerns, addressing how to use them on sick days, and what to be worried about, what not to be worried about is really important in the implementation phase. Right, moving on to the next group of drugs, it's the GLP-1 agonists. And clearly here again, these injectables, lots of good rationale for why they might be beneficial for the cardiovascular system, but also the kidney. And so we now have a group of trials that are emerging, mega trials again. I'm not going to go through all of them in the interests of time, but this is a meta-analysis which shows quite nicely. So there's been over, I think 6 now mega trials here, and you can see here for the cardiovascular outcome, I think this one's 3-point MACE, about a 12% reduction in risk of that 3-point MACE, highly significant. And again, clearly seeing here, in GLP-1s, it's not just a class effect, it's the type of exposure and use of the particular GLP-1, because as we saw with elixazenatide, you can see there no benefit. Excel, we started seeing benefit with exenatide, but with the longer-acting GLP-1s, we're seeing actually the true benefits emerge. So here we need to think about the type of GLP-1 that we're using. All right, I've just thought a lesson learned from the SGLP-1 trials, and going back to what we've heard about today, is background treatment needs to be good to see these effects. So I don't know that we would be observing these benefits if we didn't see that. So this is the HbA1c on average in the REWIND trial, which is the gelaglutide trial, and there was about 9,900 patients, was 7.3%. Not too bad, really, is it? I mean, not less than 7, but it's fairly close. Background treatment with ACE or ARB, over 80%. Use of statins, more than almost 70%. Not perfect. A mean blood pressure, not too bad. So it could be better, but not too bad. So the point I'm trying to make here is that the multi-risk factor treatment of patients in these trials, and we heard today, sometimes being in a trial is good for your prognosis, isn't it? Is really important. So when we're implementing these agents in routine clinical care, we need to, provide the same level of care around those other risk factors. All right, this is just some recent data that I thought might be interesting to this population, given it's a kidney, disease dialogue that we're having. And this is data coming out, which is pooling data of the GLP-1 receptor agonists, semaglutide and liraglutide. So from the LEADER trials and the SUSTAIN-6 trial, and it's showing the effects. Now, these are secondary exploratory outcomes. They're not the primary purpose of these trials to show benefits, but this is looking at effects of semaglutide and liraglutide on UACR, pool data over time, and you can see there significant reductions in, progression of diabetic nephropathy on those receiving semaglutide or liraglutide, and obviously the benefits for the semaglutide are greater than for the liraglutide at the higher dose. Right, so we can then look in these pooled post-hoc analysis of the leader and sustain data at the effects on EGFR, and this has become an important marker of obviously progression of kidney disease and reduced change in annual EGFR in those that are getting semaglutide and liraglutide, and obviously those getting the 1 milligram dose having a greater benefit. So we have obviously heard today around how do we then need to think about why this might be happening. Is it glucose mediated or is it other things? And you can see there they have done a mediation analysis and looking at the proportion of the benefit that might be observed here as a result of A1C lowering, and that seems to be about 25% and 26% respectively in leader and sustain of those particular GLP-1 agonists. But clearly there are other mediatory effects, including a lowering of blood pressure, body weight, and all those other things. So important effects of that sort of multi-risk factor approach to improving kidney outcomes. So my final finale is going to be looking at the dual agonists, and this is the new order.
Excuse me, Professor Zoungas, and
this last slide. Last slide. So we've got now dual and we've got now triple agonists, and tirzepatide is the first of these. And just quickly to show you, this is pooled data from the SURPASS program, and you can see there not yet significant because these are from the phase 2 and 3 trials, but a trend to benefit for the tirzepatide, and similar to what we saw with the liraglutide and the semaglutide, potential benefits for both EGFR change and albuminuria. And composite renal outcomes. So yet to emerge the SURPASS CVOT that will give us clear evidence of these drugs for cardiovascular protection. But what's particularly important here is that these trials are active. SURPASS CVOT is an active comparator trial, so it's comparing glargine, gelaglutide, a GLP-1 agonist, to a tirzepatide, which is a GIP GLP-1 agonist. All right, summary, last slide. Leader, sustain, harmony, lots of trials showing GLP-1 agonists were superior to standard care for MACE. Promising benefits for kidney outcomes, but we still need to see the dedicated kidney trials, and FLOW should report next year. There's some heterogeneity around the short-acting ones. They don't show the same benefits, and we'll look forward to those last few trials. And I will finish here, parting words. Clinical judgment is always necessary, irrespective of the evidence and the guidelines that we've been presented with. Thank you.